Welcome to our second webinar on enhancing clinical decision-making skills in shoulder-related issues. So about today's webinar, its topic is enhancing clinical decision-making skills in shoulder-related problems, a systematic approach. So the learning objective of today's webinar are: number one, why we need to improve our clinical decision-making skills. Number two is the clinical decision-making tool. Number three is the clinical history taking and red flags. Then physical examination and neurological examination assessment, differential diagnosis, rotator cuff disease, proximal bicep pathology, and labral tear pathway, shoulder instability care pathway, and adhesive capsulitis, and shoulder osteoarthritis care pathway. So the question arises why we need to improve CDM. Clinical decision when we improve our clinical decision making, it will enhance our patients' outcomes. It will improve clinical decision making, leads to better patient care and results. If we make good clinical decision, it will definitely impact the outcome of the treatment of our patients. The number two is standardizing care. We can standardize the care. Consistent decision making process ensures uniform quality of care. Number three is reducing error and misdiagnosis, which is a major issue we can see in our general practice. Even in among physicians, we can see misdiagnosis. So if we improve clinical decision making, we can reduce the misdiagnosis in our practice. And optimizing resource use, we can optimize resource use. The efficient decision making helps allocate resources more effectively. If we make a good decision, we can reduce the cost of the treatment. We can control the unnecessary investigations, so that we can control the expense of the treatment. So how to improve clinical decision making? We need to follow a systematic approach. Follow a systematic approach to clinical decision making. Without any systematic approach, we can't reach a good clinical decision. Focus on evidence-based practice, incorporate the latest research and advanced evidence into decision making. Continuing education, engage in ongoing learning and professional development. Clinical decision support tools, utilize tools which we'll discuss today as well. Resources designed to aid in decision making. And the last one is the reflective practice. What is reflective practice? Reflective practice is the clinical impression, whatever you have deal with the patient. If you have diagnosed any problem and managed any issue related to any problem of the patient, and after that you will review your management, whether you have managed it properly or not. You will find out what has been done right and what was done wrong during my management or diagnosis. So we will identify the different issues of the patient management, so that we can avoid those issues in future for other patients. So CDM tool we are going to discuss today was developed in Canada and reached consensus by promise-wide expert panel representing various health disciplines following a systematic method. They've all followed a systematic method to develop a CDM tool in which they engaged different healthcare professionals, including primary care physician, physiotherapist, chiropractitioners, and orthopedics, to develop this CDM tool with the consensus of these healthcare professionals. The clinical decision-making tool development process utilized three-round modified Delphi approach to quantify group consensus from March to September 2020. The modified Delphi approach is recommended for use in the healthcare setting as a reliable mean of determining consensus for a defined clinical problem. So components of the CDM tool include the algorithms, clinical examination algorithm for assessing, diagnosing, and managing shoulder pain, history and red flag, which include recommendation of history taking and identification of red flags and additional concerns. The third one is the physical examination and neurological screening, and then rotator cuff related differential diagnosis, then capsulitis and osteoarthritis related differential diagnosis, and instability related differential diagnosis. Thank you very much. This is all about today's topic. If you have any question related to this topic, you may ask now. So I can see some queries, some questions here in chat box. There is a Mahnoor Yusuf. He asks, is steroid injections good for frozen shoulder in elderly patient and arm crutches user patient? So as I told you that if we have to first we have to see, is it frozen shoulder or any other pathology? Yes, steroid injection is helpful in frozen shoulder. There are other options as well. There are, if there is adhesive capsulitis, there are some dilatation procedures are also there in injection therapy. They dilate the capsule to reduce the to relieve the contractures in the capsule. I think if the Mr. Amir is here available in this webinar, he is expert in this injection therapy. In elderly also, we can give steroid injection. There is no restriction. If is there any absolute contraindication is there, we can give. What will you say, Amir, on this question? She asked that.
Yeah, I think the question was very, very specific, and I pretty much very like the question. The patient is on the elbow crutches and is in pain, okay, and then whether we should do the steroid injection or not. It's a risk and benefit kind of question. So I would still do the injection, but I would prefer the dapomedrone over Canalog for this kind of patient, and I would not do muscle injection. I would do the joint injection for him. Okay? But again, it also depends on what we are looking at, what we are treating. Is it a mechanical pain, pretty much secondary to overuse of the elbow crutches, or is it something else we are treating? So lot is there to understand before we proceed with the injection. But the simple answer is we need to we will need to assess the risks and benefits. And if we still have to do the injection, I would prefer the dapomedrone over the Canalog. And if I have to do the injection for the pain management, I would go into the joint rather than in the bursa. I hope that answers the question.
Yes, thank you very much, Amit. The next question is how to check the atrophy of supraspinatus muscle as it is covered by the trapezius muscle. So the atrophy.
It's a very simple answer. It's a very simple answer. You're not gonna get the supraspinatus atrophy without the tendon torn. If the rotator cuff supraspinatus is torn and retracted, then you're gonna get the atrophy of that muscle. And then it's very easy to check with the ultrasound. You will see the fat atrophy within the muscle right underneath the trapezius muscle. But supraspinatus is not gonna get atrophied without the tendon torn. And if the tendon is intact and if it is still atrophied for some reason, then there is no clinical significance, I think.
So the next question is how do we differentiate frozen shoulder from muscle guarding? It's also a very simple question. Muscle guarding usually occurs after any trauma or any injury, but the frozen shoulder is the chronic, condition.
Frozen shoulder is normally an end product of bursitis, tendonitis, rotator cuff, capsulitis, dislocation, AC joint related issue, degenerative issues in the glenohumeral joint. Again, yes, it's a kind of a situation where you want to rehab the patient, but the patient, it is painful for the patient to move it. Again, that's where the steroid injection comes into place and the hydrodistension come into place. So what we normally do is, if it is just the movement restriction, then I would go with the hydrodistension with the 40 or 50 ml of normal saline and the lidocaine with the Canalog, 1 ml of Canalog. And if it is just the pain, with the firm and feel, I would go with the 10 ml of solution with the 1 ml of Camelog, 9 ml of 1 ml, 1% lidocaine to help relieve the pain and loosen up the protective mechanism, and then send the patient back to the physio to start the rehab.
So how do you differentiate the symptoms of rotator cuff disease from adhesive capsulitis? So in
It's
rotator
very
cuff disease, there will be no passive restriction. There will be no restriction in the passive range of motion. While in adhesive capsulitis, there will be a passive range of motion restriction will be there.
Yeah, the frozen shoulder is a clinical diagnosis.
Yes.
Okay. And like I mentioned that there is when we're talking about the rotator cuff and the frozen shoulder, they kind of what you can say work together, isn't it? The capsule and the rotator cuff, they work together. And then once you have a frozen shoulder, you need to treat the shoulder for a frozen shoulder, regardless what was the underlying pathology. Yeah. So normally what happens if somebody comes with a frozen shoulder, we still do the scan to check if the rotator cuffs are intact, there is no tendinitis going on, bursitis going on. Sometime if we have any kind of a suspicion for the avascular necrosis, then we can send the patient for X-ray to rule out avascular necrosis. And once we have the X-ray result and the ultrasound result, we will still going to treat it for the frozen shoulder, regardless how the rotator cuffs are looking like. So rotator cuff pathology, we have MRI, ultrasounds to check how they are looking like. Frozen shoulder is a clinical diagnosis and it's an end product, regardless what is going on with the shoulder.
Another question is there the difference between frozen shoulder and periarthritis shoulder. Arthritis is a degenerative disease, while the frozen shoulder is a hardening of the shoulder capsule.
I think they are interlinked, very much interlinked. If you have a degenerative or osteoarthritic shoulder, whether it's
may
an
also
AC
cause
joint,
the tightness
yeah,
of the shoulder.
whether it's an
Yes.
AC joint or a glenohumeral joint, it is not necessary that you would have the frozen shoulder. You can still have the frozen shoulder without degenerative glenohumeral joint or the AC joint, right? So they are interlinked, but they are
Interlinked.
not. Yeah, they are interlinked, but they are not specifically dependent on each other.
Each
So
yes.
you got to see what you're treating. If it is developed as a frozen shoulder, treat it as a frozen shoulder. If it isn't developed as a frozen shoulder, it's a degenerative condition, then treat it as a degenerative condition.
Assalamualaikum, sir. My name is Hava, but I have a question. If there is an axillary nerve palsy with shoulder dislocation, then how we will diagnose the nerve palsy with that as well?
Okay. Shoulder dislocation. First of all, as we discussed in our presentation as well, we have to reduce the dislocation. If the dislocation is reduced, after that we have to assess whether any structure is damaged or not. If the axillary nerve is damaged, then the axillary nerve supplies to the deltoid muscle. We have to check the function of the deltoid muscle. If the deltoid is not functional, then axillary nerve will be damaged. So first of all, with dislocation, we have to reduce the dislocation. It may happen with this dislocation, but we have to reduce the dislocation first. It will be reduced with in the emergency department, and after that we can examine the structures around the shoulder which may damage due to that dislocation. Is it
Thank you,
clear?
sir. Yes, sir. Thank you very much.
Thank you very much. Thank you, Ushna, for your support in conducting this session. I think we should conclude the session now.
Yes, sir, we should conclude. Thank you for this insightful session. And I hope everyone has enjoyed it. Everyone has get something, learned something. And for future webinars, for the recorded webinar, for the slideshow, you can check our website. The link is in the chat box. And thank you so much for joining us today. Now we're concluding the session. I'm ending the meeting. Thank you all.
Thank you. Allah Hafiz.